Hello. Welcome from beautiful and sunny Paris, from where we broadcast this session about bringing intelligence to decongestion management. This session is sponsored by Reprieve Cardiovascular, and it's my great pleasure. My name is Jan Biegus. I'm from Wrocław Medical University, Poland, to co-host this session with Julio Núñez from Valencia, Spain. And we will talk about the decongestion, the advancements of decongestion, intelligent decongestion, and the way we can actually handle the congestion in patients admitted to the to the hospital because of decompensated heart failure. We need to keep in mind that majority of patients with heart failure hospitalization actually present the congestion itself. The major objective of our session is to learn how intelligent and personalized congestion and the decongestion strategies can actually overcome the standard protocols. We will also hope that we will be able to help you understand the clinical importance of sodium-guided decongestion and to, let's say, inspire the next generation of continuum care of acutely decompensated heart failure. Without further ado, it's my great pleasure to introduce Julio Núñez, who will present the clinical case for us. Julio, the floor is yours.
Thanks, Jan, for this kind presentation. I'm happy to be here with these superheroes of decongestion. Thanks. This is a very provocative title, Jan, putting in a relevant problem, optimizing the decongestion therapy. It's a really relevant problem. We don't really know how to treat many patients. This is very important issue in clinical practice. We really know that volume overload explains most of symptoms and signs in patients with worsening heart failure. However, traditional decongestion approach are mostly cases empirical and based guided, but many cases subjective parameters. So we need precision medicine in decongestion. So in the next minutes, I'm going to present a case that illustrates this problem. This is Peter. Peter is a 73-year-old male. Patient had prior chronic heart failure, ischemic heart disease, left ventricular ejection fraction, last echo 36%. The patient is visited in a heart failure unit in stable New York Heart Class 2. Patient also has as a comorbidity permanent AFib and CKD3A. And patient is on treatment, stable treatment with furosemide 80 milligrams daily, sacubitril valsartan low doses, bisoprolol 5 milligrams daily, eplerenone 25 daily, and dapagliflozin. Patient, we may say that patient is optimized in terms of GDMT. The patient came to emergency department with progressive dyspnea, decreased urinary output, peripheral edema, evidence symptoms, signs of volume overload. No identifiable precipitating factor. The patient on admission had blood pressure 90/60, heart rate 92, AFib, GFR 41, and NT-proBNP, high NT-proBNP, higher than close to 1,000 picograms milliliter, and evident signs of volume overload also expressed by higher values of CA125, a marker of extravascular volume overload. Here in emergency room, patient received an echo exam that reveals severe left ventricular systolic dysfunction and severe MR and severe tricuspid regurgitation. The patient received intravenous furosemide dose at 160 milligrams daily. Was initially prescribed. At this moment, the physician decided to stop sacubitril valsartan and eplerenone, and the patient was admitted to cardiology ward. The evolution of patient the next days, patient in the first day, the urinary output was slightly above 2 liters. Dyspnea slight improvement, The day 2, 3 was the same, slight improvement in terms of symptoms, signs, with daily urinary output about slightly above 2 liters. The day 4 patient refers to be better. Patient wants to go home. Everyone wants to be home, and the physician decided to discharge the patient to home day 5. No clear algorithm, no clear protocol, just patient feel a little bit better. The patient was discharged on the same guideline medical therapy for pillars, including sacubitril, valsartan, beta blockers, pleromone, and SGLT2 inhibitor, together with furosemide dose daily of 120 milligrams daily. The patient was scheduled for an early post-discharge visit in the heart failure unit. What happens with the patient with this conventional approach? Patient came once again 7 days after discharge with recongestion. Look at the patient, evident symptoms, signs of volume overload. And this is not an anecdotal story. This is highly frequent story. This is a sad story that happens in up to 30% at 90 days after discharge. So we really have a problem. So at this moment, I would like to introduce Marta Cobo that will try to help us how to improve this traditional, conventional diuretic approach. We are failing with this one.
Thank you, Julio. Well, in the next session, we will review the state of the science and conventional decongestion, current practices, what the guidelines recommends, and what we have learned from recent clinical trials. And we all agree with Julio that too many patients are discharged with residual congestion. And to help improve the numbers Julio just showed us, the Heart Failure Association published this consensus document in 2019 that was later incorporated in the European Heart Failure Guidelines. And this was the first structured framework that provided a step-by-step protocol that helped us in assessing the diuretic response in acute heart failure. And let me walk through it. The first thing is straightforward. When the patient is admitted in the emergency room with volume overload, please administer intravenous loop diuretic as soon as possible. If the patient is already on diuretic therapy, administer 1 to 2 times the dose the patient was taking at home. This high dose comes from the iHF trial that was the first study that evaluated diuretic strategies in acute heart failure. And the key finding was that the high dose therapy, defined as 2.5, the oral dose, resulted in greater symptom relief and a better decongestion 72 hours later. And after this initial treatment, the document proposes one of the key things of the document: please be proactive, perform an early evaluation of diuretic response by measuring urinary sodium at 2 hours and urinary volume after 6 hours. Because as Dr. De La Spriella will explain shortly, a low urinary sodium, particularly below 50 millicubic liters, is associated with a worse diuretic response and increased risk of rehospitalization and mortality during follow-up. Therefore, if the urinary sodium is low or the diuresis is low, the protocol recommends escalate the loop diuretic dose until a maximum dose of 400 to 600 milligrams of furosemide. And from the second day onwards, the protocol recommends first reassess the congestion. And there it is, another important message from this document. Given the limitations of physical examination on detecting residual congestion, this guidance recommends a multiparametric assessment of fluid overload, incorporating biomarkers and imaging techniques such as vena cava imaging and lung ultrasound. And please let me add 3 additional tools that may help us, like CA125, that is a very useful biomarker in detecting tissue congestion, the Vexus score that helps us to identify intravascular congestion by measuring the venous flow of porta, suprahepatic, and renal veins, and the increase of weight with its well-known limitations. So if we detect residual congestion and the urinary output is below 3 liters, an escalation of therapy is recommended. This 3 liters threshold was evaluated in the CARES-HF trial. That was an interesting study that evaluated a protocol diuretic treatment versus ultrafiltration in patients with acute heart failure and cardiorenal syndrome. It was based on the previous oral dose, and it consisted of intravenous bolus, the addition of a continuous infusion, and the addition of metolazone if needed. And this protocol led to a better renal preservation compared to ultrafiltration. And finally, the protocol recommends combination diuretic therapy, but only when a high loop diuretic therapy has been reached. But however, this recommendation seems outdated given the recent trials that have evaluated a second diuretic, like the chlorotic with the hydrochlorothiazide, the Advor with the acetazolamide, or the Impulse with the empagliflozin. All of them show that an earlier combination leads to an earlier and more effective decongestion. And this brings us with Julio's patient, with Peter, and he was admitted during a trip to Madrid. And despite we applied the European document, we administered twice the dose, we performed an early evaluation, we escalated on day 1 to the maximum loop diuretic, added dapagliflozin, and on the 3rd day, we also added chlortalidone. The initial evolution was good, as you can see in the slide, by losing weight, the clinical examination, but we needed to escalate further, adding acetosalamide, spironolactone, and even applying venous leg compression after achieving euvolemia 32 days after admission. Therefore, although I feel that we are moving in the right direction, I really think that we need to better assess diuretic response in order to translate it into an earlier and more effective therapeutical decisions. Thank you.
Thank you very much, Marta. And now I would like to introduce Dr. Rafael Espilla, who will talk about the science behind decongestion management and why we fail in, I would say, some standard protocols. Rafa.
Thank you very much, Jan. In the next few minutes, I'm going to discuss with you the reasons why I think we need to change our current practice using traditional metrics like daily weight loss or net fluid balance to a more science-based approach, which is urinary sodium. This is my disclosures. Which are the problems with the commonly used metrics for assessing diuretic response? We all use changes in weight loss or net fluid output to assess the decongestion of patients admitted because of an admission with acute heart failure. And these metrics are applied in current clinical practice and also in trials. But the reality, if we look at the data, this is data from the DOSE trial, ESCAPE trial, and the PEN cohort. If you see the Bland-Altman plots here, there is a substantial disagreement between changes in weight and net fluid output, which puts us in evidence that if these metrics are essentially measuring the same signal, how is possible to have this substantial lack of correlation between those? There are a number of reasons. This indicates that one or both of the metrics are incorrect in a substantial percentage of cases. If we see the fluid balance side, there are a number of reasons like uncorrected intake, staff and patients non-adherence, food and fluid intake, which is not measured. And if we see the daily weight challenges are basically on different scales used, the patient, which is fragile and his inability to stand to the scale, the bed scale problems. I mean, this is a challenge that we also see in daily practice, that lack of the accurateness of these metrics. Even if we have dedicated staff nurses with motivated and are able to do these metrics in an accurate way, there is a substantial delay between we have this data and we modify current treatment. Diuretics are almost titrate or set the dose 1 per day, and we have the information the day after. So we always are the information, the gesture information, we almost 24 hours behind, and we make decisions based on these metrics that are inaccurate, that are delayed, and that are not associated with better outcomes, as you can see here. Both metrics are highly variable, and in current trials have not shown any consistent benefit in terms of outcomes. So we need a paradigm shift. We need to bear in mind that the pathophysiology of extracellular volume expansion is not based on water retention. It's basically on sodium retention, and net fluid and weight loss are most entirely the result of changes in water. If you see these two patients here, patient number 1 and patient number 2, they both had the same urinary volume, 2.3 liters in 24 hours. You may say this is a good response, but if we look at the urine content, you can see that patient number 1 has a substantial lower urinary sodium in 24 hours. It's basically a merely dilated urine, whereas the patient number 2 is actually desalinating, is excreting an amount of sodium that is what we want. And this has several prognostic implications. This is data from the iHF trial, and you can see here that patients with a negative sodium balance, a negative fluid balance, but still positive sodium balance are those who have the worst prognosis. So this is a therapeutic target. And how we can use a parameter that can ideally give us information both of sodium removal, but also on sodium removal. This is the natriuretic response predicted equation from the group of Jeffrey Tistani. And as you can see here in the graph below, there is a almost linear association between the predicted urinary sodium equation and the actual measured sodium output. And with a very good, in every threshold that they measured, there is a good correlation with the observed urinary sodium output and urinary output. But we need to bear in mind that it's not just important to have the urinary sodium at just one point during the decongestion assessment. This is data from Jan showing us that the trajectory of urinary sodium during admission is also important, and patients who we achieved a negative sodium balance with a substantial higher urinary sodium during admission had better prognosis than those who achieve a lower and progressively lower urinary sodium during the first 48 hours of decongestion management. But we also need to have in mind that even if you have the same urinary volume during the days of admission, the urinary content is going to be progressively dropping in the next few days because of two main points. Because you are achieving a negative sodium balance, which is your objective, or because the patient is not responding in an appropriate way. And the best way to integrate this information is by combining these parameters with, of course, clinical examination and other multiparametric parameters to see which of these conditions is what you're facing on. The most potent and strongest evidence so far about the role of urinary sodium and outcomes is data from the ADVOR trial, in which you can see here that a patient achieving a greater natriuretic response was associated with faster decongestion, and this translates into a shorter length of stay. And if you see at the right, assessing urinary sodium as a continuous variable, you can see clearly that above 80 of weighted urinary sodium, there is a progressive protective effect during the next 90 days after the discharge. So this is a therapeutic target in our patients. However, in practice, there are a number of barriers that preclude us to use this useful metric in our daily practice. This is data from a Spanish national survey, including more than 165 hospitals and more than 400 physicians with diverse specialties. And you can see here that implementation of urinary sodium in practice is around 20 to the best of 30%. There are a number of reasons of that: lack of protocols, therapeutic inertia, time on human resources, but this is the reality. So we need more actionable and automatic strategies. This is an example of the gel diuretic pathway that uses an automatic approach based on the natriuretic predicted response equation, in which every 6 hours the nurse have the result of the system and tell her exactly which is the next dose that she needs to prescribe to patients. And this translates into an improvement in total urine output, net fluid output, and weight loss using this algorithm. So in conclusion, we need to move away from the traditional metrics, and the science tells us that sodium is the target, and probably an automatic approach is the better way to achieve this. So in the next minutes, Jan is going to tell us about the intelligent decongestion management with the Reprieve cardiovascular system. Jan?
Thank you, Rafa. Thank you very much, and I will try to get you facilitated with intelligent decongestion in a few minutes. These are my disclosures. I would like to start with the notion that we've been using loop diuretics for 6 decades, but how we use it is more like a try and error decongestion, as was already mentioned, rather than, I would say, personalized approach. Although we've been using the drug for more than 60 years, there are several unanswered questions, like what is the best starting dose of the loop diuretics in a single patient that we actually need to treat, what response should we measure, when should we reassess the patient, and what is the optimal timing of the next dose of the loop diuretics. So taking all this together, we are, I would say, far away from something that we could call a personalized decongestion. Although, of course, as you see here on the left side of the graph, the graph showing our attempt based on urinary sodium. So the subject of this lecture is intelligent decongestion. So I just wanted to point out several features that this intelligent decongestion should have. And what I think it should have, it should be personalized, which means it should be adjusted to the single patient. It should allow us for dynamic, real-time adjustment for the therapy, changing during the therapy. It should, of course, preserve the renal function, prevent both over decongestion as well as leaving a patient with residual congestion. And it should, of course, integrate several signals like urine output, fluid balance, clinical status, and other physiological responses into the one decision-making algorithm. And, of course, making it easy and detectable early identification of inadequate patients with inadequate diuretic response. So Reprieve therapy is something that gets us closer to this goal because the device itself is actually connected to the patient with a line that can actually administer loop diuretics in a real time. It also is connected through the urinary catheter and can measure the response, urinary volume. And the third thing that it actually does, it also infuses the saline during the decongestion, which is quite, I would say, not so straightforward for most of us, but it actually is meant to prevent both sodium and intravascular volume depletion. And as you see here, there is a graph showing the decongestion of one patient during the Reprieve therapy. And during this therapy, actually the red line is something that shows you the dose of the loop diuretics. So there are like 3 or 4 boluses of loop diuretics, which were followed by a continuous infusion, which allowed actually a smooth decongestion. So what does this device do? First of all, it is much closer to the personalized medicine because it actually has something that is called rapid dose finding algorithm that allows the device to find the dose that is effective in a single patient, in a single individual. Then it allows to maintain the dose and re-ramp if necessary during the therapy. And the third thing that will probably be discussed later on, it actually allows the infusion of the saline. So FAST trial is a trial that was meant to test the Reprieve therapy against standard of care, and patients with vast fluid overload were randomized in a one-to-one fashion in a randomized controlled pilot study, showing that the patients eligible for the trial were patients with vast fluid overload, almost more than 4.5 kilograms of estimated fluid overload, and patients with eGFR less than 20 were actually excluded. So the primary endpoint of the trial was efficacy endpoint was 24-hour urine sodium output, and as you see here, there are around 100 patients were randomized, 52 into Reprieve arm and 44 into the optimal medical treatment arm. The patients were in their 60s with eGFR around 55, 57, and ejection fraction just less than 40. So here you can see the distribution of the loop diuretic dose the patient received, and you can clearly see that on the blue that patients on a device received much higher dose of loop diuretics, but it translated into shorter duration of the therapy, and it was also associated with an infusion of the saline approximately 3.3 liters per patient. In terms of efficacy and safety results, the Reprieve therapy had significantly higher natriuresis normalized for 24 hours. It was safe, as you see, there was no safety signals. And as you see here, it not only natriuresis itself, but net sodium excretion as well as total urine output as well as weight loss was significantly better in patients allocated to the Reprieve therapy. There is, of course, a hypothesis-generating graph showing the risk of recurrence of heart failure, hospitalization, and death during 90 days of after the treatment. To put the whole results into the perspective of other trials in acute heart failure, you can clearly see that during the Reprieve therapy, the weight loss was significantly higher than in other trials, and it was actually related with lower risk of worsening of renal function over the controls compared to the other therapies. So to conclude, in fluid overloaded patients, Reprieve therapy was associated with faster and more favorable effects on sodium output, urine output, weight loss, with no signals regarding the kidney harm or any other safety signals. With that, I will conclude, and I will give back the floor to Rafa, who will show us the case again.
Yeah, and here we have a typical case of a patient who is admitted because of decompensated heart failure. It was a 50-year-old male with a left ventricular ejection fraction of 40%, a moderate mitral regurgitation, and was previously admitted before. And when we see the physical exam, he has substantial signs of fluid expansion, leg edema 4+, crackles, orthopnea, increased jugular venous pressure, also pleural effusion, and an estimated excess volume of around 8 liters. The vital signs and weight, the blood pressure was 128/75. The weight was 101 kilograms, with very high NT-proBNP, with a serum creatinine of 1.3 and GFR about 60. Serum sodium 137 and potassium 4.5, And in red here, we show parameters indicative of probable diuretic resistance as serum chloride of 98 and urinary sodium after the initial bolus of furosemide of 80 milligrams of 83, less than 100. So the treatment prior to admission was furosemide 40 milligrams, dapagliflozin 10 milligrams, spironolactone 25, and was receiving valsartan 160 milligrams. So the patient was admitted, fulfilled the criteria, the eligibility criteria to be enrolled in the FAST trial, and was allocated to the Reprieve system arm. And as you can see here, this is the response. In the first part, the upper part, you see that the diuretic infusion rate, as Jan explained before, the system, the first phase is the dose finding phase, in which the system is going to deliver a continuous infusion of furosemide to achieve a target of 525 milliliters per hour of diuresis during the first 2 hours. And during this initial dose finding phase, the system will automatically infuse saline in a 1-to-1 ratio to achieve or 250 milliliters of saline or 1 hour, whichever comes first. After that, a continuous infusion phase begins with 20% of the dose finding dose that was achieved during the dose finding phase. And as you can see here in the lower graph, the urinary rate was initially very fast, increasing the rate of urine. Also, the saline rate was fast, but after the first infusion, the urine rate becomes back down again. And the system asked the physician to administer a new ramp to achieve a higher infusion phase. And this was what occurred. As you can see, there was an increase in the urine rate again that was maintained during therapy. And in the yellow line, you can see the saline rate that was around 300 milliliters per hour. So the net fluid balance in green, the green line, was drawing back to the negative of 8 liters. And the resume of the therapy, you can see here that the duration of the therapy was around 20 hours with a total urine or around almost 12 liters with an average of 161 milliliters per hour. The fluid volume replaced as a part of the Reprieve therapy was around 4 liters. The total volume removed was negative 7.4 liters with an average per hour of 360. The total furosemide administered was around 900 milligrams with an average of 43 milligrams per hour. It's a very high dose. The estimated fluid that was 8 liters, we achieved our goal, and the patient was successfully decongested and was discharged less than 48 hours from admission. And now, how we can overcome after we achieve the decongestion itself, how can get the patient out of the hospital, and that's what Alex is going to tell us.
Yeah, thank you very, very much. Now, there is a secret in this case report, is that the patient came to Paris. And then together with you guys, we are going to see how we are going to manage this patient. And bravo to show this case, because it's really a case that we are all facing. A patient who initially came, looks beautiful when he was discharged first, and then he came back again with a new discharge, with a new congestion, and then you discharge him very well after an active decongestion. Now the question is, how are we going to manage this patient? Now, as I said, you did very well the first hours, combining oxygen if needed, and this is what we published few years ago, saying that for decades, and Jan was mentioning earlier, the action was during the first minutes. How can we decongest the patient? And we know that, in fact, the journey of acute heart failure is a little bit more complex. The patient is staying at the hospital. Julio said earlier, we have a problem with those patients that would like to leave the hospital as early as possible, and we need to use that period before discharge to really manage this patient as much as we can. Then again, I took your patients who took an airplane to come to Paris, and here's the hemodynamics that you showed. Here's the biology, very high NT-proBNP, almost 6,500. Creatinine slightly increased, eGFR 58. Potassium 4.5, I think it's important to mention this. And the oral therapy was valsartan, 40 milligram times 2, spironolactone 25, and dapagliflozin 10 milligram. Now, what are we going to face, and we already faced this in this patient, is that at discharge, and Marta, you said it earlier, we all think that the patient is discharged and he's euvolemic, and we know that we are wrong. Even if we are writing in the report that the patient is euvolemic and normovolemic, we know that it's not true. Many of them are discharged with still a congestion. And I like to show this data, because this data we asked to the physician in charge, so the cardiologist in charge, how was the patient at admission? You see that at admission, 70% were wet and warm, but we told the same cardiologist, but when the patient is discharged, how was it? And you see that when really they're examining the patient, almost 1/3 is still discharged when they're leaving the hospital. And I used to remember people that in this study, many of the patients had a body weight that was even higher at discharge than really at admission. And we should keep this in mind, and this echo, I think, what you showed earlier. Then we did a strong procedure, and the strong procedure came a little bit really from the concept of cancer, saying when the patient has a cancer, and we know that heart failure is really, unfortunately, killing patients more than any cancer. We had this idea to say when the patient comes with an acute heart failure, even more importantly in your scenario, because the patient came again and again, we should really start the oral medication that is going to cut this neuroendocrine system. And what we did was strong. We indeed gave oral diuretics, but we also gave to the patient literally half of the dose of ACE or ARNI, half of the dose, optimal dose of beta blocker, and half of MRA together in the morning, together in the mouth of the patient to start really oral medication. Then the patient was discharged, and in the protocol, we said this patient cannot be left alone and going back and not being followed. We said, okay, those patients are clearly in emergency. We need to see them back very, very quickly. And we decided to see them in the weeks following discharge. Now, this result is interesting. In red is the patients we followed. In blue is the patients that unfortunately were followed in town. And you see that the management is unfortunately poor. But let's focus on those who the investigator managed in the high-intensity care arm. And you can see, for example, let's look on beta blocker at 90 days. You see that beta blocker at 90 days, half of the patient could have a full dose. And it's important to see that even at 90 days, we hardly could give a full dose to more than 50% of the patient. But this is already great because we go from few percent to half of the patient. And the other patients, they are not left without anything. You see that the other patient had between, as you can see, between half and full dose. And really we can say that 80% of the patients who came with an acute heart failure had the minimum half and even a full dose. Was it translated in outcome? Yes. And maybe during the discussion we will come back to this. Although it looks counterintuitive to have patients with congestion, that we start the medications before discharge and we give early after discharge, yes, if you push the fire, if you push the treatment, you can achieve an improvement in many parameters, and indeed readmission and death. But this is really, for me, one of the most important slides, because this was not expected. It's not something that we looked for, and we were surprised to see in the high-intensity care arm, although there was a slightly lower dose of diuretics, we saw all the parameters of decongestion being improved at 90 days. And I love to show this analysis of Jan Biegus-Sinchak, showing that on the y-axis you have decongestion, then 0.75, 0.50, etc., means that the patient is more and more decongested. And you see that the more the dose of GDMT are close to the optimal dose at 90 days, the more the patient is decongested. Now, Strong was repeated in several settings. This is in Harvard, Jim Januzzi and Spahilari. They did echo before and after the implementation of Strong. They could show first that the patient is better, is improving. NYHA class has really improved. But also we see in only few months, we see a remodeling. Ejection fraction is better, 6%, but maybe even more importantly, the volume of the left atria and the left ventricle are down. And indeed, by definition, we saw an improvement of mitral regurgitation. And this is now seen by many groups. And really, I love to show this data to show that this effect, this powerful effect of starting the medication before discharge, we see it already 1 week after discharge. We measured in this study done in Tunisia, we measured respiration rate on the top left, and on the top right, we measured SpO2. And you see that within 1 week, this is really unbelievable. Within 1 week, we saw respiration rate coming back to normal, and we saw SpO2 coming back to normal. Then it's not only congestion that probably went very quickly, but there's also many other neuroendocrine systems in place that were improved. And you see that in this trial, indeed, we confirmed that at 90 days and 180 days, there was an improvement in readmission and death. This led to this recommendation that you know before discharge and after the follow-up visit. In these guidelines, they said, please extend it at least for the first 3 months to any ejection fraction. And they also said, please add a gliflozin. This is important. And I would like also to show you this network results that was done in China. As you can see here, more than 600 accredited centers, more than 400,000 acute heart failure patients. And in fact, we accredited those centers. And you see here that within 12 months of putting a GDMT implementation, within 12 months, let's say if we, in the country, the Minister of Health said today we start, March the next year, we already would see a decrease in the readmission and survival. And you see that, interestingly, implementation is improving every year, means that with the same centers, with the same network, because the nurses, medical students, etc., everybody is learning, then you see that every additional year it's good. Then coming back to this lovely patient who would like to see the Eiffel Tower, then before discharge, at least this would be my way of doing, and maybe we can discuss this later. 40 milligram would have been slow for me, a low dose. Then I would go for a higher dose because the NT-proBNP, remember, was very high, 6.5. And because I'm thinking beta blocker would be probably better tolerated if we can decongest the patient, then I would go for higher. I will keep the medication that you put, and I would start with bisoprolol 2.5. At week 2, indeed, I'm going to check what I did before discharge. Then I would see whether whether furosemide was the right dose or whether I need to increase. And this is based on NT-proBNP. Indeed, if I start to see NT-proBNP going down, I will rethink increasing the dose. But if NT-proBNP would stay the same, definitely I will increase even more furosemide. Valsartan blood pressure was good. Then valsartan I would go to 160 times 2. Spironolactone I would go to 50 if potassium is really unchanged. Dapagliflozin would stay the same. And based on heart rate and based on the NT-proBNP that we heard earlier, either I pause bisoprolol or I would keep going again, because my idea is here is the more there is optimal dose, the more I will decongest the patient. Thank you very much.
Thank you so much.
Hello. Well, now it's a pleasure to me to moderate this session with such great speakers. And if the audience have any questions, they can send it to the tablet. And now, well, we can start with any question for our speakers. Marta, Rafa speak about the obtained urinary sodium at 2 hours. Well, how is urine sodium currently measured and used in your clinical practice? If you can detect some barriers, and how do you change it
Okay, well, as I showed in the protocol, the guidelines recommend us to assess urinary sodium in a spot urinary spot at 2 hours after the first loop diuretic administration. But I think we have a time window of 6 hours in which low natriuresis can help us to improve, to increase diuretic treatment. Afterwards, as Rafael explained perfectly, as sodium excess is removed, the urine becomes hypotonic, and we don't really know if a low natriuresis is related to inadequate decongestion or if the patient is diuretic unresponsive. So I think in that moment it's very important to assess the multiparametric approach of congestion, and if the urinary sodium is low, perhaps we need to push harder, but no evidence. We don't have no evidence. And regarding the other question, we, as Rafa showed us, we performed a national survey, and it was really striking. Only 18% used this natriuretic guided strategy, and the main barriers were the lack of training. And I think this is one thing that we should improve, because the emergency department physicians, at least in Spain, are the first physicians who attend the patient. So I think we need to improve these pathways and the training. And the other limitation was that half of the respondents perceived a low clinical priority. And I think it's true that natriuresis-guided therapy has not shown reduced hospitalization or reduced mortality, but I think, like heart failure specialists, we need to highlight the importance of an earlier decongestion. And I think we should improve in research, but I think we should highlight that.
Jan,
can I just add to this? Two comments. First one is that if the awareness, I'm afraid that in Poland it will be like 10% centers actually measuring sodium, but it is probably because lack of awareness. This is what you just said. So this is great that we can talk about it and just say that this is very important. And the second thing is that we did the research, and we know now that we don't really need to wait this 2 hours, right? If the patient empties their urinary bladder and then we give them the diuretic, so we can measure actually the first urine that comes after this IV diuretic, and usually it's around 1 hour, and this is almost the same as the sample that is taken at 2 hours. So this might actually make life easier for the clinicians, right? That you don't really need to set the clock and say, okay, in 2 hours I'll be back, but you can just take the sample that is first post loop diuretic dose.
Well, one question from the audience. In acute decompensated heart failure, patients with significant congestion after starting diuretics, if patient develop rise in bone and creatinine, should I reduce the diuretics if it's still congested clinically?
I can answer that, yes. It is expected to have an initial rise in creatinine during decongestion, and this should not give us a signal to stop diuretics, especially if we are absolutely certain that the patient is still congested, because this is not a signal of kidney injury itself. It's more an hemodynamic process that is happening within the glomerulus, and we need to continue diuretics because of this is the only way to improve outcomes.
Okay. Jan?
Can I just add a little bit to this? It might sound a little bit controversial, but actually what we learn from Reprieve and what we really do in our everyday clinical practice, if we have a situation like this, we have a patient with fluid overload who urinates like 3 liters per day, and his creatinine goes up. From my perspective, is information that we need to give the fluid, sodium and chloride to this patient. And actually Reprieve therapy shows it that the risk of this scenario is much lower in patients who receive this signal. We don't really know what the signal is, but the signal probably we prevent intravascular depletion and sodium, relative sodium depletion, but this is what we do. And we do not stop the treatment, we do not decrease the treatment, but we try to adapt to the situation.
Well, Julio?
Just a summary for all of you that are listening and viewing us. It's really important to leave behind just interpretation of GFR or serum creatinine in this type of patients and integrate, in a multi-parametric perspective, putting in first place, clinical evolution of patients, diuresis, natriuresis. This is relevant. And leave behind a comprehensive interpretation of renal changes into this multi-comprehensive assessment.
Okay, perfect. Julio, other question. Short question, short answer, please. What are the main indications for Reprieve system and what are the best candidates for it?
We really don't know, but if we check the results of faster trial and the eligibility criteria for this trial that is ongoing, we need to focus on patients with fluid overload, and risk of insufficient diuretic response. Okay. I think in this scenario, the machine of this Reprieve system will achieve positive results.
Perfect. Jan, for you, what is the importance of the saline, isotonic saline in this trial, and why is so important for these results?
Thank you for the question, but I will not be short. There's no way to be short to answering this question, but to be honest, well, I think the graph, I showed you the graph with the dose of loop diuretics that both arms received, and the Reprieve arm actually received much higher doses of the loop diuretics, and it was super safe, right? So I think that giving back the saline during the decongestion, how I understand it, from physiological point of view, I think that we actually prevent something that is intravascular depletion. When the kidneys start to excrete a lot of volume, then there is a risk of shrinkage of the intravascular space because the refilling rate may not, accommodate for the urine output. So this is the first one, and the second one, I feel this is my personal, I would say, belief that we can, let's say, blunt the inner signal, physiological signal for the kidney to stop producing the urine because of the fact that it get rid a lot of sodium. If we give the sodium back, this actually makes it like the kidney is still producing a lot of volume.
Perfect. Other question is if you have to prevent or be aware with any situation along the trial, Rafael?
Yeah, absolutely. If you are giving a gram of furosemide and patients are producing 10 liters of urine per day, it is possible to get electrolyte abnormalities during this process, and you should monitor carefully the acid-base balance and electrolytes to prevent these complications that may happen during this substantial diuresis. So I think it is important to have these patients well controlled, and in fact, during the trial, you have to make at least 2 determinations of electrolytes in each patient to control of these problems.
I just want to point out that these potential side effects, this is not because of Reprieve system. This is a potential safety issues about aggressive diuretic treatment.
Exactly.
Yeah.
Well, other question from the audience. During the diuretic therapy, if clinically congestion has improved but not NT-proBNP is still high, Then we try increasing diuretics to reduce NT-proBNP also. Julio, Jan, Alexander.
I can take that one. I think NT-proBNP number rarely lies. I think if NT-proBNP, especially Marta mentioned this earlier, if you look on the evolution of NT-proBNP, maybe the first number could be related to many parameters, but if you have already one number, really the evolution, whether it goes up, stay stable, or go down, it's really very significant. Then I understand your point. The patient did a lot of diuresis, but NT-proBNP is still high, which we see often, we see very often. Really, there is something wrong, and the heart is still not coming back to normal. Then we should keep this in mind.
The only thing I would like to add is interpret the NT-proBNP in the context of the creatinine, because sometimes if the creatinine is high, then the NT-proBNP also increases and it's not reflected congestion. But I also agree with you that it's a signal of that something is happening.
Okay, perfect. 2 questions.
I'm
Rafa.
We have time only for one question.
One question. One question. Alexander.
Ula.
It is important to initiate GDMT titration before discharge.
But then it's easy. Yes.
Yes, that's the. So we have a time for second question.
Patient with severe congestion or ansarca.
Very quickly. One, we really need to start before discharge, because for many reasons, including psychology, the patient, when he sees that you start several medications before discharge, he understands that something is wrong. And 2, I know it looks counterintuitive by saying, but the patient is still not decongested, how you start? Yes, we really need to start.
Can I ask you something about the case? I kind of missed the sacubitril valsartan there, very high-risk patient. Why not changing valsartan for sacubitril valsartan in an earlier stage?
Yeah, in fact, I try to not be provocative, because in many countries, you first need to increase valsartan, and usually the switch is later. But you're right, we can do it early.
Now I would like to ask Julio just to give us just a brief comment and end the discussion, please.
Yes, thanks, Jan. I would like to congratulate all of you, because excellent talks. I have learned a lot about this session, and also to be here in Paris is beautiful city and beautiful landscapes. So it's time to take home message. I think that really important topics we have discussed. First, we have appropriate decongestion remains a challenge, remains an unmet need. We are improving. I think we are on the right way. However, there are a lot of things to do. I think this is the first take-home message. Second, we need to move forward from this traditional conventional diuretic approach, mainly based on empirical thoughts, subjective parameters, into a more precision medicine approach. I think it's absolutely necessary. In this regard, I think that urinary sodium emerges as a crucial parameter, crucial biomarker for getting this objective. I think that all of you that treat this type of patient, worsening heart failure, fluid overload, aggressive diuretic response, need to integrate urinary sodium for monitoring and guidance therapy. I think it's absolutely necessary. But this is not a final history. We have an additional potential novel strategies for continuing improving. And in this regard, Reprieve systems emerge as a promising approach for optimizing the congestion in patients with fluid overload and insufficient diuretic response. This is physiological sounds. We palliate, we control extravascular volume expansion, but keeping intravascular volume and avoiding all deleterious effects of intravascular depletion. I think we need results, but at least theoretically for me it's absolutely marvelous. And finally, I say that we need to continue searching the right decongestion approach in our daily clinical practice. Thank you.
Thank you very much.
Thank you.